Hello, I'm Matthew Weinstock, Managing Editor of Modern Healthcare. Thanks for tuning in to the latest edition of The Checkup. HCA Healthcare has weathered the coronavirus pandemic a little bit better than most health systems. In fact, earlier this month, the hospital chain announced that it was paying back nearly $6 billion in federal pandemic relief funding. Part of HCA's ability to navigate the pandemic can certainly be attributed to a long-standing approach the organization's had to crunch data in real time, become what they call a learning organization, and spread best practices. And I'm really pleased today to welcome Dr. Jonathan Perlin to join us. He's President of Clinical Services and Chief Medical Officer at HCA to talk about some of these efforts. John, thanks so much for being with us today. We know it's busy.
Matthew, it's really great to see you, and a delight to engage with you and colleagues on a dialogue around COVID and improving healthcare.
Great, thanks. So let's start sort of a state of play where we are now. On HCA's earnings call earlier in October, I think it was noted that you had about 40,000 COVID patients in Q3. We're seeing some surges across the country, including some of your markets continue. Flu season's coming up. Just walk us through what your capacity is like at this point.
Yeah, well, let me put it this way, is that as of today, this is Wednesday, October 14th, we've taken care of 62,414 COVID positive inpatients, taken care of quite a number more of individuals who've been ruled out for COVID. We've done approaching 1.5 million outpatient tests, cared for over 150,000 outpatient COVID patients. I think the biggest learning is, it falls into a few buckets. First, we've learned how to take care of COVID better. In fact, to the point of being a learning health system, which I'll just define as one that commits to using the data that are invariably created as a byproduct of the care itself to learn and improve the system, and most importantly, to channel information back to the individual patient to improve care. It's allowed us to actually increase survival for COVID by 28%. That is, if you were admitted in March or April, compared to today, you have a 28% better chance of surviving. So we've learned a lot in that regard. Second, in terms of capacity, you're absolutely right. We are beginning to see an uptick in the country. It's not surprising. Experts indicated that with cold weather, as we congregate more inside, that we'd see the respiratory viruses, and certainly influenza is one of those. We haven't seen flu significantly yet. A reminder here, everybody get your flu shots. It's your social responsibility. You also don't want to be confused with a COVID patient, so get your flu shot. But we are seeing, as people go back to school, as families congregate indoors, that at different parts of the country, there's a little bit of an uptick. I think there are a few important points around this. When the country first faced COVID in March and April, everyone else stayed away from healthcare, despite the fact that they were having heart attacks and strokes and broken bones. It was quite remarkable what healthcare people did without. I'm sure we'll come back to that point. But it was just COVID. And then there was a second surge where the peak was really mid to late July. For us, it was July 21st. We had to take care of not only COVID patients, but patients with heart attacks and strokes and things equally significant. And that challenged us. But it also challenged us to learn how to read what we call the 5 S's of surge to make sure that we have the capacity to be open for business. And those 5 S's first are, what are the community trends? First S is spikes. What are the community trends? What's going on? What is going to tell us for the other 4 S indicators whether we're prepared to meet that surge or need to scale down some of the other activity? Those other 4 S's are space, and that actually turns out in many ways to be the least problematic. If we need to, we can flex the recovery rooms, that is post-anesthetic care units, into ICUs. We can increase the acuity on the floor, but space is the first S we look at. The second is supplies. Supplies were actually much better shape than we were those months ago in terms of the personal protective equipment, PPE, as well as the lab testing supplies. In fact, we've increased our testing capacity internally by roughly 300% since the beginning of COVID, and to meet the demand pretty substantially. The third is staffing, and that's really the most critical part. There's been a lot of learning in that regard, but we want to make sure we have the adequate nursing coverage, respiratory therapist coverage, physician coverage. And the biggest lesson there is how to cross-train and make sure that we can provide the resources necessary to care for both COVID and non-COVID patients. And the final S is support, and that's really life support, and that's ventilator capacity, and in this day and age, ECMO, and we can talk more about why that's becoming somewhat of a more interesting resuscitative therapy. But those 5 S's then are community spikes, space, the supplies, the staffing, and the life support. And so those are our triggers, and we essentially have a red, yellow, green, and green means go. We're open for all sorts of activity. Yellow means that we've seen some changes in the community rates and our own indicators, and we want to sort of temper things a bit. And just parenthetically, elective activity does not really impact ICU, but there are other ways in which we can temper activity. Also parenthetically, just because things we call elective means that they're scheduled, but that doesn't necessarily equate to it being truly discretionary. It might be a cancer therapy or the like, but we can modulate those things in yellow. And red is a condition I hope we don't get to, but it's one we invoked in July where we shut down certain services in deference to meeting capacity and community needs for COVID care.
And one of the things I know you did was expand sort of protocols for bringing people back in for elective surgeries, right? Can you talk about how that process has worked, and can that be scaled elsewhere?
Matthew, we think that it can not only be scaled, but that it should be scaled, because really the protocol that we adopted, we did a bit of a test internally. We took one group of hospital and patients, and we did universal for testing for everybody. And we took another group and we created an algorithm based on some guidance from CDC and elsewhere that stratified into high risk, that is, people with exposures or undergoing a procedure that would likely generate an aerosol and expose the operative team. And that latter protocol-driven approach only used testing for a select group. Guess what? There was virtually no difference between universal testing and the protocol-driven testing in identifying COVID patients. And that was actually something we published in a paper, I have it here, the American Journal of Surgery. And it's really useful because it conserves some of the resources for testing for patients who may really need that testing more critically. More importantly, though, and this is the other aspect toward really generalization more broadly, we adopted a posture, even before the CDC, of universal protection. We went to universal masking early on. We made a call that we instituted means to conserve the use of masks, but that in the care environment, we would have individuals wear masks. So the reason we did this is that while testing is extremely valuable, it's possible to overread the utility of the test. What do I mean by that? Well, positive means positive, but do you really trust a negative? Positive means positive, but negative may not be negative. So we want to make sure that we have the personal protective equipment, most importantly, the masks, the physical distancing in our care environments as possible to ensure safety. And that's allowed us to have very low rates of better rates than we've seen reported elsewhere of transmission in care environments. In fact, it may be safer than the community in terms of transmission rates. But it allows us also to conserve the testing so that can be used for one, patients who are ill, or two, doing the sorts of tracing that you'd want to do to really control the transmission in a community, particularly during an increased spike of an outbreak.
Right, interesting. And along those lines too, on your earnings call earlier this month, it sounds like a lot of postponed care is starting to be rescheduled. And I imagine that's up and down depending on the market. But can you talk about just sort of lessons learned and what you're hearing from patients in terms of their willingness to return as the pandemic continues? And are there things that you're trying to share across all the markets?
Yeah. So as our CEO, Sam Hazen, said on the earnings call, about 68% of the care that had been deferred has either been completed or rescheduled. And so we are seeing a willingness of patients to return. That's great, because we were really worried about some of the things that we were seeing decreases in. Well, you may think of certain procedures as truly discretionary or elective. We saw, as was reported in the New England Journal and everywhere else, decreases in patient presentations for stroke and for heart attack. In, I believe it was the May 8th New England Journal, there had been a 29% decrease in U.S. presentations, continental U.S., for stroke. I am absolutely certain that there was not a 29% decrease in stroke. I am certain that there was a 29% decrease in patients presenting. Stroke is really a brain attack, and time is brain. The quicker you can actually restore blood flow, the more function that's preserved. We saw even greater decreases in presenting for chest pain, and that's catastrophic. In our New Orleans area, Tulane is part of the HCA family. They work very closely with the emergency medical system there. And the EMS was saying that they were reaching patients who were sicker. So the American Hospital Association has just initiated a campaign to get needed care. And we think that's so important. So we think that patients are beginning to realize that, this COVID thing is not going away. I think they're also realizing that hospitals and healthcare environments, as with the best community organizations, are learning how to manage risk. They're learning how to manage their own risk, feeling safer. And there may be some who aren't back there yet, but increasingly, I think the lesson is that if COVID has had two waves already, initial COVID, quiescence, a resurgence, other care happening, quieter period again, if we do have another surge on the hospital end, not only do we increasingly know how to scale up or scale back other activities, but importantly, we know how to keep patients safe. And I think patients are increasingly beginning to understand that, as well as, I hate to be Debbie Downer on this, I don't see, and I don't think they see, COVID going away in the near future. So even for some of those things that might be put off, I think the calculus becomes, how long can I take the pain of needing a hip replacement or the like? So I think the lesson for health systems, the lessons for us, the lessons for governmental leaders are really that the next era is not waiting for after COVID, but the next era is really coexisting with COVID, being safe with COVID, and to the extent our personal risk tolerance allows, really sort of resuming life, albeit in a socially responsible manner.
Interesting. You referenced something there that I want to get at in the last couple minutes we have here, the scale up, scale down, which, hospital organizations aren't necessarily used to, but you're doing during this period. So what kind of strain does that put on you? And as a learning organization, what kind of opportunities does it present for you to scale up, scale down, scale up, scale down?
Yeah, well, first, I don't want to miss the opportunity to really express sincere thanks to all of my colleagues at the very front lines of care. I don't think any of us here in Nashville, even though we've been here virtually every day for months, experienced the stress, the challenges of managing not only their healthcare responsibilities, but their personal lives. And so please know how grateful we are, not only to our HCA healthcare family, but to all care providers at the very front end.
Right.
We are learning. Some people say they want to eliminate variation. My goal is to harvest variation. We want to harvest variation on the top end. We want to understand what leads to the best outcomes. We're learning how to use steroids most effectively. We're learning how to go back to the literature. We went back to the literature and found that something that's really difficult for nurses to do, but is life-saving for patients. We know from the early work on acute respiratory distress syndrome, ARDS, that putting the patients on their belly, called proning, actually increases the capacity to breathe, and it can prevent ventilator. We attribute the decrease in mortality for many patients and the ability not to have to go to a ventilator to that sort of system learning. We've introduced systems. We have a decision support system called NATE and it allows us to track across the entirety of HCA what patients who have COVID, well, first off, we can see the patient. Second, we can see whether we're clustering them to reduce exposures and conserve personal protective equipment. The third, we can also, thanks to our care providers at the front end, find out what the respiratory status is, whether for those patients on ventilators, a couple of things that were known but seem to have been forgotten, that the tidal volume isn't too great, or the pressure too high, plateau pressure too high, or proning are put in place. And we can use these mechanisms to really improve care. As I said, a 28% increase in survival from the beginning of COVID to now. Really proud of what our frontline folks are doing. What I think is important, this is not only a learning mechanism for COVID, but these are durable tools that make us better for the longer haul. Other lessons that I think are tremendously important is that we've seen staff flex from their usual activities when surge occurs and perhaps you're temping down in one particular area. We're becoming multi-skilled to be able to provide care in other areas, and that's forcing us to have more standardized processes. And as a sort of quality guy, I know that those standardized processes lead to better care outcomes. You opened the call with the fact that we're able to return to the federal government $6 billion of care assistance. For us, good quality is good business. Show me a process that meanders to diagnosis, I'll show you waste. Show me a process that meanders to the right therapy, I'll show you waste. If we can get to the best and most appropriate diagnosis and most appropriate care most efficiently, not only are we serving the patient with safer and more effective and ultimately more compassionate care, but we're eliminating waste. And it's that sort of dexterity with data that I think is allowing us to be effective as we've been in the face of really unprecedented challenge, not only in terms of the broad scope of the pandemic, but affecting virtually all markets simultaneously, but by virtue of the protracted duration. And so we're out there learning with our colleagues. We're delighted that we formed tighter relationships with our public health colleagues, importantly, community constituencies where the health systems are working together to really meet the needs. I think these are some of the things that we believe will be durable as we serve both COVID and patient care more generally.
Well, that's great, John. We definitely appreciate you sharing some of the insights that you've learned there at HCA and how you're expanding that across or spreading those across the entire system. So thank you so much for taking some time. We know it's busy, but we appreciate the insights.
Matthew, it's been a delight to be with you, and we appreciate you and all of our colleagues, particularly at this moment.
Thanks so much, and stay safe.
Thanks.
And I'm Matthew Weinstock with Modern Healthcare. Be sure to check us out next Monday on The Checkup. Thanks.